All right, let's see if anyone is. No, it's just us two today. Cool. Okay. We've got quite a few questions to get through, but it'll be quite nice. It'll be nice to go through them with and have a think about it.
I hate progress CSA. It's like the one thing I struggle with.
They're real hard. I think they're real hard.
But then I do fine in modules. And Roger Booth was like, it's to wheedle out people who aren't that good at module tests.
And you were like,
I'm alright at modules. I just suck at progress tests.
Alright, so first question. 23-year-old man presents to ED after falling off his bicycle. X-ray reveals posterior humeral midshaft fracture. What nerve is most at risk from his fracture? Axillary nerve, radial nerve, ulnar nerve, median nerve.
Well, this is the humerus, isn't it?
Mm-hmm.
So, midshaft. I would answer, I don't know.
So, I personally don't remember either. I had to look this up in my notes. But if we remember from Musculo, we learned about the triangular space and triangular interval and the quadrangular space.
I can't remember any of that. Are these your Musculo notes?
Oh, these are just like all my notes. But if we have a look here, you've got your scapula, your humerus, teres minor, teres major, and your long-headed bicep. Tricep, sorry. And you've got your triangular interval and your quadrangular space, and the interval is below the quadrangular space. And essentially, the radial nerve runs through the triangular interval, and it is damaged when you have a fracture of the humerus.
Oh, see, I don't remember any of that.
That's all right. That's why we're here.
Yeah, but am I supposed to remember Musculo? I feel like that's the only one I don't really remember that much from.
Oh, that's right. There'll be 3 or 4 questions.
Oh, okay.
It depends on what you want to put your time into. And the axillary nerve comes out through the quadrangular space, and that's damaged when someone has normally a posterior dislocation of their shoulder.
We taught that?
Yes.
Oh, shit. Sorry.
No, you're right. So the answer is radial nerve because it's a fracture, and fracture of the humerus can
cause radial nerve
damage. And then the other important learning point from this is dislocation of the shoulder causes axillary nerve damage.
Okay, what about the other two?
The other two are not implicated in these spaces.
Oh, okay.
Cool, okay. Next question. 23-year-old Samoan man attends the emergency department after dislocating his shoulder playing rugby. His friend, who is a doctor, has tried unsuccessfully to relocate his shoulder. The emergency nurse practitioner is managing the case and you are helping him. What type of joint is the glenohumeral joint? Is it synarthrosis, primary synchondrosis, secondary synchondrosis, or a diarthrosis?
I'm not going to know any of the muscular ones, I'm sorry.
It's alright, there's only a few of them and then we're moving on. So, these are the different types of joints. A synarthrosis, it always goes bone, something or other bone. So synarthrosis is like bone, fibrous bone. So that's like the skull.
Yeah.
Skull. A primary synchondrosis is bone. Okay, I'm going to have to, I think it's bone. Yes, cartilage bone. So that's like your ribs, bone, cartilage bone. And a secondary synchondrosis is bone, cartilage, fiber. Cartilage bone, and that's like your intervertebral discs.
Yeah,
like the discs. Yeah, and then a diarthrosis is what we think of as joints. So bone, cartilage, joint space.
Yeah,
cartilage, bone.
Okay.
So shoulder, knee, fingers. Those are all diarthroses. So pretty much everything is a diarthrosis. That if you think of your classic joint, if it's got a joint space, then it's a diarthrosis.
Joint space diarthrosis. Okay.
Yeah. So there we go. Diarthrosis.
Sweet.
Cool. Surely this is jogs memory a bit. Yeah. A 24-year-old male Māori forestry worker presents with severe and worsening left forearm and wrist pain after crushing his forearm between 2 heavy logs of wood at work. An X-ray shows mid-shaft fractures, I can say the word, of the radius and the ulna, he develops compartment syndrome. What is not a syndrome of compartment syndrome?
Painlessness.
What is it? What should it be?
Pain.
Yeah, it's super, super, super painful. So, pain. So, what are the
5 P's?
Yeah.
Pain, paresthesia, pulselessness, pallor, and pain.
And perishing cold. That's the last one. But actually, they're all quite like late presentations. The most common one is pain. It really, really, really hurts.
I do remember that one.
And other ones that they don't mention but are very clinically relevant. Let's say you've got a patient and they've got their arm in a cast and they're like, oh man, my hand really hurts. If you grab their fingers, which will be curled in like this, and try and pull it back, it will really hurt. Like, it will hurt so much.
Yeah.
And that is a very, very classic sign. And you'll be like, okay, this person's got compartment syndrome.
It's like a build-up of pressure or something
so
like
you
that.
could get compartment syndrome. In this example, he has, so you've got those spaces, deep compartments within your arm where you have quite thick fascia surrounding muscles and what's the word? Arteries and veins as well. And if you have an increased amount of pressure in those compartments are so stiff they can't expand, and so it presses down instead on the arteries and the veins.
So it can't.
Yeah.
Okay, I get that.
And so it's very painful. And the other ones, these are all late, but pulselessness, that's if the pressure in the compartment is higher than the pressure of the artery running through it.
That makes sense, yeah.
Paresthesia is tingling and numbing, which you can get at kind of sort of, I would say, mid. So
I'm guessing you go pale because of the blood flows, not?
Yes, correct. And then perishing cold, no blood flow, very cold hand. But number one is painlessness. It's very painful. Very good. Okay. A 65-year-old woman presents to orthopedic clinic complaining of weakness of her left shoulder. When she stands with her hands pressed against the wall, her left scapula shows a characteristic winging appearance. What are the nerve roots of the nerve supplying the affected muscle? This is a very specific question. So, winging scapula, what is the muscle that holds your scapula up against your spine, so to speak?
At the back? Trapezius?
Kind of, close. That's what I would have said, like, yesterday until I wrote this question. It's serratus anterior. It holds your scapula up against your back.
So do you think it will benefit me to... I did make a table when I did MS of, like... I remember learning all the insertions and like the nerves, but I didn't write the test. But I
would look through it mostly for its clinical relevance. So this example.
But then, do you go over all your notes for module tests before progress?
Yes, but only if they're clinically relevant.
Oh, okay.
So this is an example of the clinically relevant one, and it's
relevant. So do you have a folder of clinically relevant?
Yeah, there we go. That's what I would go over. So this is a brachial plexus question. Your long thoracic nerve originates from C5, C6 and C7 and comes down and innervates serratus anterior, which helps pull your shoulder blade into your shoulder.
How do you know that? I don't even remember.
That's right. I don't know. But it's C5, 6, 7. And the other one that you could rule out is C3, 4, 5.
That keeps the diaphragm alive.
Very good. Yeah,
so I would have ruled that one.
If you can rule one out. If you can rule two out, then definitely go for the question.
Yeah, I do. Well, my new strategy is going to be if I can narrow it down to 3, answer.
Oh, that's pretty good.
4, I wouldn't answer.
No, I agree. So, C5, 6, 7, long thoracic nerve supplying serratus anterior muscle. Next question. 75-year-old woman presents to orthopedic clinic, worsening tingling and weakness in her left hand. It gets worse at night. She often has to wake up in the middle of the night and shake her hand awake. Have you heard of this in an older woman? What nerve has been affected? Axillary nerve, median, radial ulnar.
Is it not axillary?
Not axillary. Yeah, you got one out.
Not radial?
Not radial. You're right.
Because I just remember median and ulnar having some sensation in the hand.
Very good.
But that's
Does it
all
help
I
you
can
if
do.
I say one of the other tests you would look at is the muscle bulk of her thumb here?
Yeah, one's thenar.
Yeah, so the thenar muscles, they're innervated by
It's one of the two.
the median nerve.
Median.
So this is your classic median nerve palsy. It's also called carpal tunnel syndrome.
Okay. Oh, okay.
So carpal tunnel often happens in old ladies. And it's here you've got your retinaculum in your hand over your wrist, and there's just increased pressure build up, and it traps the median nerve and presses down on it, especially if you've been doing something. So the test that we learn, Tinnell's test is, or Tinyell's, I don't know how to say it, is you tap their hand just above their wrist and it'll like irritate the nerve and it'll cause that tingling and pain. Or the other one is you get them to do, I think, upside down prayer for 60 seconds. That's called Phelan's test. And then if they get it again,
Do you think this is working in the hospital has helped you remember all this?
Yes.
Okay, that's good.
I did orthopedics. So
okay.
But this is stuff that, all the stuff's in our notes, so, in the muscular notes. But it's cool to like think about it, like, oh, this patient had it, so it's fine. So yeah, median nerve palsy, carpal tunnel. And do you know, can you guess what the treatment for carpal tunnel is?
Release that pressure.
Exactly, decompression. They just do a little cut and get all the fluid out, and then it's fine. All right, next question. A 10-year-old Nuan child presents with a 2-day history of limp from a painful knee. That's the most important bit of that entire question. What is the most common bacterium causing osteomyelitis? What is osteomyelitis?
Is that like a bone infection?
Very good. So what's the most common bacterium? Staphylococcus epidermis, Streptococcus pyogenes, E. coli, Staph aureus.
It's either B or D.
And probably in the New Zealand Middlemore setting. It's probably Staph aureus. Yeah. So I would say Staph aureus would be the answer, and that's what the literature that I looked at said was right. But Strep pyogenes is another good example of something that can cause osteomyelitis. Staph epidermis I haven't really heard of. I think it can in E. coli. Not really.
No. Yeah.
Cool, that was easy. I think with those questions about bugs, it's kind of like you know it or you don't. But you got it down to 2 immediately, so boom.
Yeah, I feel like the answer is always one of the. I mean, Staph aureus is usually. I'd go for Staph aureus.
Oh, can you think of what the treatment might be for osteomyelitis? You wash it out.
How do you wash out bone?
You literally, like, drill some holes in it and wash it out.
Would that not be painful?
No, it removes the pain. It's very painful to have an active infection.
Do you...
Wash it out, it feels real good. And then you put them on IV antibiotics for ages.
Are you knocked out when you...
Yes.
Okay.
Yes, you are. Right, next question. 20-year-old man arrives by ambulance after... Oh, those are all our muscular questions. Now doing easy questions. 20-year-old man arrives by ambulance after being hit on the side of the head in a brawl. He initially loses consciousness, then gains his consciousness, then he slips into unconsciousness again. So what sort of hemorrhage has he experienced? Subarachnoid, subdural, extradural, subcranial.
I would say not B or D. Because I don't... Subdural is not usually due to trauma, is it? It's more like... Because isn't that the vein? That's why elderly get it a lot.
Yes, so...
Or it can be due to trauma, but it's not as common.
Correct. So subdural is in between our dural layers, and we've got those venous sinuses there. That's correct. If the patient turned up with a subdural hemorrhage, what would their symptoms be like?
Can people watch this and listen to me?
Yes, but no.
Oh, okay. That's so weird. I'm not really sure. I can't remember learning.
That's all right. So subdural hemorrhage is insidious. So they start getting a headache and then it gets worse and worse and worse.
I thought you'd get a headache with all of them, though.
Well, you do, but it's the different types of headache. So you definitely get a headache with a subdural hemorrhage. It's normally because of damage to the sinuses that you were talking about, which is very good. And on a CT scan, it looks like a banana.
I remember that. I do remember that.
D does not exist.
Yeah,
D is not a thing. So A or C?
Is it extradural?
Correct. So an extradural hemorrhage is a skull fracture.
Yeah, I remember it being a big skull fracture one.
Causing damage to especially if you hit it in the pterion here. Very good, middle meningeal artery. Very common for people to regain consciousness and then deteriorate again. And if we looked at it on a CT, if subdural is banana, extradural is a
like a wedge.
Limon.
Yeah.
And then a subarachnoid, that is a cerebral hemorrhage. And they have very quick loss of consciousness after a thunderclap headache. So that's
thunderclap.
Yes, so excruciatingly painful headache, and then they lose consciousness. So that's the classic subarachnoid hemorrhage.
Okay,
cool. 28-year-old woman presents with a lump at the front of her throat. When you ask her to stick her tongue out, the lump moves upwards. So what is the cause of this lump? Thyroglossal cyst, lymphadenopathy, branchial cyst, or an abscess?
Is it B? I mean A.
Why is it A?
Because I remember what is it? It starts off, it's called a thyroglossal cyst when, like, the embryology of the thyroid gland, it doesn't, like, migrate properly or something like that.
So the thyroid gland starts kind of at the bottom of your tongue and then migrates down to where it sits here, like
and it might something like the thyroglossal duct.
Yeah, very good, and it follows, tracks down the
so that's why it's
duct.
Called that if it doesn't.
And sometimes some of it doesn't go all the way down and gets stuck here. And because it started at the base of the tongue, it's connected up to the tongue. So if you get them to poke their tongue out and you watch it very carefully, it'll go whoop and move up and then go down again. Or get them to drink a glass of water, and as they drink the water, you get them to hold the water in their mouth and then get them to swallow. And when they swallow, the lump will move up and down with their tongue. So that's classic thyroglossal cyst.
Did you make these?
Yes.
Pretty good.
Oh, thanks. Oh, I didn't even highlight A's right. That's sad. Okay, lymphadenopathy, what's that?
Enlarged lymph node.
Exactly. And where in the neck would we find that?
Aren't there quite a few of them?
Exactly, anywhere. So lymphadenopathy, it could be like down up above your supraclavicular, it could be in your posterior auricular area, it could be coming down. There's heaps of lymph nodes underneath your jaw, submandibular. You would probably have something like, maybe you had a viral infection, or you might have had an abscess in your mouth, or you might have had, like, there's a reason why you've got your lymphadenopathy, and there's a difference between painless and painful lymph nodes. Painless is normally worse.
Yeah.
Painful is all right, and they should last for less than a week, less than a couple of weeks, and if they've been around for quite a long time, that's a problem. A branchial cyst, do you know what that is? So do you remember when you had to make an embryo in first year and you had those little somites on the side, down the side of the spine? So they come and migrate around to the front and then like zip up in the middle, and if they haven't come around properly, they leave a lump, and that's a branchial cyst.
Oh, okay.
Which is really interesting. And
would you not discover that before?
Yeah, I don't know why. I don't know why people who they must just be like, oh wow, this has actually been annoying me for a long time. I'm going to check it out. But it's just a remnant of embryology, and then an abscess. What would make you think something is a lump on their neck is an abscess?
I'm not sure. I just wouldn't think that was.
An abscess is like a really horrible fat boil or like a pimple or something. So they're hot, extremely painful, swollen, red, obviously infected.
Yeah.
And then they go under anaesthetic and we chop them out. Cool. Okay. Question 9. A 2-month-old New Zealand European boy is brought to the GP by his mother. She is concerned because since about a week ago he has been much more irritable than her first child and has been crying for 2 hours tonight. He seems to be tugging at both his earlobes. He has a temperature of 38.2. What is the management for this condition? So what is the condition that you think he's got?
I'm not sure.
So he's been sick for about a week, all irritable and crying a lot. He's got a temperature and he's been tugging at both of his ears. Got an ear infection? Yep. Probably acute otitis media. And management of this condition. So this is a bit not complicated, but with kids who have ear infections, often we will, if they come like the day that they've started to get an ear infection, we'll wait, see for 48 hours if it improves, and if it doesn't, then we treat them with antibiotics. So that's the only antibiotic there is amoxicillin.
So you wait before you treat them?
If they've just turned up and they've only just started having symptoms, but this kid's been sick for a week. Other things is age, so if they're, I think, younger than, I've written it down, if they're younger than 6 months, got bilateral otitis media, or they've got fever, so this kid's got heaps of all the problems, then you want to give them amoxicillin.
Yeah. That's right.
And when we're looking at the eardrum with our otoscope, what sort of things do you reckon we'll see?
Retracted.
Oh, very good, yep. It'll be red and inflamed.
Inflammation. Yeah.
Oh, it could be retracted, or it depends actually. Retracted, yes, but it could also bulge out.
Okay.
So it depends on the pressure gradient. It could either be suction or bulge out. And it will not be nice and see-through like normal. Cool. Okay, question 10. And we didn't go through the other things. You wouldn't lubricating eardrops know that's if they had like problems with earwax. You'd give eardrops. Liquid Pamol, you would give it to them for the fever and the irritableness, but not to treat the ear infection. And reassurance, no, you don't tell them. Don't say, Mum, you're crazy. Alright, question 10. 56-year-old hypermetropic, long-sighted, Chinese woman presents to emergency GP with painful red right eye, which began earlier in the evening. She also complains of nausea. On examination, the right pupil is fixed and mid-dilated, and the cornea is slightly hazy. To palpitation, the right eye feels hard in comparison with the left eye. What is the most probable cause of this condition? Macular degeneration, keratoconus, thyroid eye disease, or acute angle glaucoma?
Oh, she's old. Oh, painful red right eye.
So let's go through the picture. There's specific things that they've put in here that make us think it's one of these four answers more than the other ones. So long-sighted, your increased risk of one of these conditions if you're long-sighted. Painful eye, lots of the conditions down here aren't actually painful. Nauseous.
I swear we didn't learn any of that though.
This was an ophthalmology.
Really? I remember these, I just don't remember like whether they're not painful.
Well, the other important thing is the right eye feels hard compared to the left eye. So feels hard. What would make your eye feel harder? If you've got increased pressure in your eye, it would feel harder than the other eye, wouldn't it?
Is keratoconus, is that rugby ball?
Very good, yep, so it's not keratoconus. Do you think thyroid eye disease would turn up without any mention of any thyroid problems? No, so it's either macular degeneration or acute angle glaucoma.
I was gonna start with A.
Well, if this presented, so this began earlier in the evening, so this is a very acute
macular degeneration, isn't it? Okay, so it's D.
So it's D, yeah, very good. So it's acute angle closure glaucoma. Let's just talk about glaucoma. So glaucoma is increased risks when you're like sort of 40 to 60, which this person is, long-sighted, which this person is, and Asian people have an increased risk of glaucoma. There's acute and the acute angle, and then there's like one that isn't acute angle, but we won't talk about the other one, we'll just talk about acute angle here. And essentially your eye is producing fluid and draining fluid all the time, and then when sometimes, for instance, if you're long-sighted and you walk into like a dark room, your pupils dilate heaps and it accidentally blocks off the draining system for your eye. And so your eye is producing lots of fluid, but it can't drain it. And so the pressure inside the eye begins to increase and increase and increase, and it's very painful, and it gets red. The pupil can't move anymore, so it's fixed and dilated. Cornea is a little bit hazy, and on palpation it's harder. And if there's heaps of pressure, what do you think would be a complication of glaucoma if we don't treat it? So what it does is it pushes up against the optic nerve and kills the cells of the optic nerve.
So you could lose your vision.
You could lose your vision, exactly. Did I put the treatment here? Yes, I did. So you can treat by reducing the fluid in your eye. Beta blockers reduce the fluid produced in the first place.
Beta blockers?
Yeah. And then there's a drug called pilocarpine, which opens up that angle between opens up where the fluid has to drain. It's an emergency glaucoma. You want to fix it as soon as possible, otherwise people they become blind in one eye. Macular degeneration, what is that?
Isn't that common with old age?
Correct, yeah. It's just degeneration of the macula. The macula is where your central vision is when you're looking at something and you're focusing on it.
So
the light's hitting your macula.
Blind patches kind of, isn't it?
Yeah, so you start losing the ability to see central vision. And then there's dry and wet macular degeneration, and they're just two different types. And we didn't really learn about that, but that's all right. Blurry vision, not being able to focus properly, is the key symptom because your macula doesn't work. So keratoconus is rugby ball eye. It's if you rub your eyes all the time, then there's also genetic factors. So environmental plus genetic factors lead to your cornea thinning.
Double hit hypothesis.
Very good, yeah. Your cornea thins out and then it becomes all disformed. And symptoms: blurry vision, double vision, astigmatism, light sensitivity. And then thyroid eye disease. So this is seen in late stage hyperthyroidism, like in Graves' disease. And you can't close your eyes properly. Your eyes are all inflamed. You've got thick recti muscles, and your eyes are popped out. It looks freaky. So they don't have thyroid eye disease, this person, luckily. All right. Next question. 78-year-old woman who has a goiter removed about 2 months ago, and she presents to her GP with a hoarse voice. What nerve was probably damaged during her goiter removal? Vagus nerve, recurrent laryngeal nerve, accessory nerve, or occipital nerve?
Recurrent laryngeal?
Yes. Tell me about the recurrent laryngeal
nerve. Branch of the vagus?
Yes, very good, yep.
I just remember it innervating a lot of the
so it innervates your larynx.
And around the area.
Yeah. And I think it also does innervate your thyroid, you're right. So it comes down either side of your neck, branches off the vagus nerve, and then it comes down, and on the left...
One's subclavian, one's archivale.
So on the right it loops around the subclavian, and on the left it loops around the aorta, and then it comes back up again, which is very interesting. I'm not quite sure why. But it's not vagus. Accessory nerve, what does accessory nerve innervate?
Those two. Sternocleidomastoid and trapezius.
Yeah, so when someone says, what does accessory nerve innervate, you shrug your shoulders because it innervates the traps. And occipital nerve kind of doesn't exist. It's like a sensory nerve. Very good. What is a goiter?
It's like an enlarged thyroid.
Due to iodine deficiency. Alright, so yeah, thyroid question, very good. 32-year-old Chinese woman presented originally with an overactive thyroid gland. She was treated with carbimazole, which downregulates thyroid hormone, thyroid function, but suffered side effects, so she was then treated with radioactive iodine. She attends a follow-up clinic with fatigue, lethargy, and feeling cold all the time. What would you recommend for this patient? So without looking at the answers, we should be doing that cover-up thing that good old Bridge Booth was telling us, but never mind. Radioactive iodine, what does that do?
I'm not sure what the radioactive part of it is about.
So it kills it. If you give someone radioactive iodine, it destroys their thyroid.
Why would you give someone that then?
Because her thyroid is overproducing hormones. So it was overproducing hormones. They gave.
So her, now is it kind of had the opposite effect?
Very good. So now she's got no thyroid. Not iodine, because she doesn't have any thyroid left.
Okay.
So no thyroid gland can't produce T4 or T3.
Oh, what about the
So
thyroid?
Levothyroxine is the synthetic version of thyroid hormone.
Yeah.
Very good. Yeah.
Okay.
So that's what we're going to give it. So this is a classic presentation of...
That's confusing.
Yeah, it is a bit confusing, but I think it makes a lot of sense. So someone presents with overactive thyroid. So you give them a treatment for that, but the treatment doesn't work. So you're like, well, the next thing, you can either remove the thyroid surgically or ablate it with radioactive iodine. So the radioactive iodine, so iodine is used by the thyroid to produce T4 and T3, and the radioactive iodine is absorbed into the cells, just like normal iodine, and then it destroys the cells that it's taken up in. And you have to like take the medication in a like lead-lined room and stuff. It's really funny. Anyway,
I feel like that one's to do with labour. Is it?
Might be. That one, that's a calcium channel blocker. The reason I put nifedipine in...
So it's to... Oh, okay.
The reason I put nifedipine in is because she was feeling cold all the time. And one of the differential diagnoses you could think about in this patient is Raynaud's phenomenon. So Raynaud's phenomenon, do you remember they showed pictures of people who had like white fingers with no blood flow? That's Raynaud's. And treatment of Raynaud's is calcium channel blocker to relax the vessels.
That makes sense.
Yeah, so that's one of the possible differentials, but that's not the answer.
Okay.
What's fluoxetine? It's Prozac, SSRI, antidepressant. Because people who have hypothyroidism are sometimes diagnosed with depression, not hypothyroidism, because it's one of the
So
symptoms
it's a cause
is
of
feeling...
depression?
Yes,
Hypothyroid.
hypo, yeah.
Oh,
and
okay.
hyperthyroidism is associated with anxiety.
That makes sense.
Because you're like, if you think about it, if you've got heaps and heaps of like thyroid hormone, you're like real jacked up, like, I don't know what to do, and you get really hot. People who have Graves or hyperthyroidism are really hot and uncomfortable all the time and on edge. People who have hypothyroidism are cold and sad and slow, and they have dry skin and thin hair. Iodine is what we would treat if someone had goiter or iodine deficiency. And if you
in this case, your thyroid's not even there.
That's right, so we can't.
Okay.
If you have an iodine deficiency and you get pregnant and give birth to a child, what problem could they have? That's very terrible.
I don't really only know is iodine.
That's right.
Supposed to
They
improve
probably
IQ. So is it something?
Yeah, it's called cretism.
Oh yeah.
And it's very uncommon nowadays because we put iodine in our salt and now everyone's got iodine. Yes, it was a problem with women getting pregnant who had goiters or iodine deficiency. But yeah, thyroid hormone stuff is actually quite easy, and I think, do you remember maybe you guys don't, but in RDA, when I was there, we had like a chart of like hyper, facetious or factitious hypothyroidism, and it's all about like what your TSH and your T4 does. So if you've got hypothyroidism, your thyroid is producing less thyroid hormone compared to the thyroid stimulating hormone, so you're going to have high TSH,
and
low T3 for T4. And then with hyperthyroidism, it's that negative feedback, so you're going to have low TSH and high.
I remember that.
Very good. An 88-year-old woman is referred to the endocrinologist with symptoms of depression, a blood pressure of 180/90, constipation and bone pain. She had a renal stone last month and blood tests showed raised calcium but low phosphate. So what is the probable cause of her symptoms? Osteomyelitis, hyperparathyroidism, osteopenia or vitamin D deficiency?
I feel like vitamin D deficiency. Maybe?
Why would you say that?
Because of the low phosphate.
Oh, yeah, that's true.
But it's not that, is it?
No, I think not this question. But I think that's it's a good differential. One of the reasons why we're thinking it might not be vitamin D deficiency is very, very high blood pressure and constipation.
What does constipation mean in this sense?
Well, if we think about she's got raised calcium, what organ?
Oh, PTH.
Yeah. What organ releases hormones that improve our calcium levels?
Hyperparathyroidism.
Very good, hyperparathyroidism, yeah. So
okay, that makes sense.
hyperparathyroidism is, that's the right answer, bones, stones, abdominal groans, and psychiatric moans. So that's how you try and remember it. But sore bone, like bone pain, abdominal problems, constipation, high blood pressure, drinking all the time, depressed, renal stones. And it's all because there's too much calcium. So renal stones, calcium.
Yeah.
Constipation because your parathyroid hormone interacts with your stomach absorbing calcium. So it's absorbing too much.
I remember that.
Thirst because you're thirsty because there's so much calcium in your blood. Yeah, so osteomyelitis is infection in your bone. We had it before. Osteopenia is low bone density. Okay, next question. A 25-year-old man presents to the GP clinic complaining about obesity. He has a round face, very thin skin, abdominal striae, and a blood pressure of 160/90. He has a sports injury a few months ago for which he was prescribed prednisone by a different doctor. What is the likely cause of his symptoms?
What's prednisone?
It's a steroid. So Cushing's syndrome, hypocalcemia, osteomalacia, or primary adrenal failure.
Cushing's.
Very good. So
cortisol.
There are a few causes of Cushing's. There's you give yourself Cushing's through medication, and then there are a couple of other ways you can have Cushing's.
I feel like there's some sort of endocrinology reason as to why.
Yeah, so it's your adrenal glands, and your adrenal glands are stimulated by your pituitary. So you can either have the pituitary sending off too much adrenal, ACTH, I think it is. Yeah, ACTH. And then the ACTH stimulates the adrenal gland, and you've got too much cortisol excess, or you've got something like an adrenal tumor that's producing cortisol excess. So I think it's primary is in the kidney or in the adrenal gland, and secondary is in your pituitary gland.
Yeah. Okay, that makes sense. But this is like an exogenous reason.
Correct. Good word, exogenous, exactly. If this was caused by a pituitary problem, what is another very important side effect that we would see? It's a bit left field, but they would be very, very dark. And it's because overproduction of ACTH.
Melatonin.
Yeah, I think it's called
something. More ACTH equals more MSH or something.
Optimelanocortin, POMC.
Oh yeah.
And
which equals more MSH.
Yeah, and that makes people go very, very dark.
Yep.
And then if it's just at the level of the adrenal glands, hyperpigmentation doesn't occur because of that negative feedback. So now the ACTH is being dampened down. And then if we go through the other ones, hypercalcemia is too much calcium, like increased PTH, we talked about it before, too much vitamin D, hypercalcemia, and you'll have constipation, peeing a lot. What am I saying?
Is it like weak bones?
See, osteomalacia, weak bones. And primary adrenal failure is a problem with the adrenal gland itself. And that also you look dark in because you've got lots of ACTH being produced trying to stimulate the adrenal gland.
I guess they wouldn't really mention the medication though if they wanted you.
Very correct. Like very true. Okay, next question. A 35-year-old New Zealand European male with a 15-year history of type 1 diabetes, mellitus, presents with repeated low blood glucose levels. In the past, he's felt sweaty and irritable when his glucose was low, but these symptoms seem to have stopped. He has nearly lost consciousness a couple of occasions and is worried that this might happen when he's driving. What is the cause of his symptoms? He has increased tolerance to his normal insulin dose. He has cured his diabetes. He has developed type 2 diabetes. He has developed hypoglycemia unawareness.
I don't think it's B or C.
B or what?
B or C.
No, he's cured his diabetes.
Could it be D?
Yep, so why do we think it's D?
It's like, I can't really remember it, but your body becomes kind of like used to, like accepts the new norm of this.
Exactly, yep, so you've got two,
low insulin.
there are two types of responses your body can have to low blood sugar. And the first one is, I'm going to make these numbers up, but like less than 5. Let's say blood glucose of less than 5. You feel sick and sweaty and upset and angry and like yuck. And then less than like 3 or 2, you start getting drowsy, confused, lose consciousness, die. And if you have too many low blood sugar levels, you start the autonomic response, which is the sweating and the feeling sick, you start to not have that anymore. Your body gets used to it and accepts, oh, this is normal. But the issue is the threshold for losing consciousness doesn't change. So instead you're like warning the
warning signal.
The time in between the warning signals and losing consciousness gets smaller and smaller and smaller and smaller. So that is hypoglycemia unawareness.
Okay. I remember that.
Oh, that's good. So while we're here, type 1 diabetes, what's that normally caused by?
That's more of a genetic thing.
Yep.
I feel like type 2 is more acquired.
Correct. So type 1 is autoimmune normally. Destruction of the islet of Langerhans, beta cells. Most commonly diagnosed in kids. And you've got, do you remember talking about like the honeymoon phase? The pathogenesis of type 1 diabetes is you have your beta cells get attacked, and then the attack goes away, so they're like now 90% effective, and then there's another attack, and now they're 80% effective. And over the course of probably years, they start losing more and more bulk, and after you've lost about 90%, you start getting the symptoms of type 1 diabetes. So what are some symptoms? So one is drinking all the time, being really thirsty.
Peeing lots?
And then having to pee it all out, because your kidneys are trying to get rid of all the sugar that's in your blood, but they can't get rid of it. You lose weight. You're tired.
Yeah, because type 2 is overweight and type 1. Yeah, okay.
Yeah, and people will often present to the GP with diabetic ketoacidosis, where because they can't use blood sugar anymore, they start breaking down fat to use as a source, and the fat breakdown causes ketone release. Ketones cause acidosis. Acidosis is very bad. So most people with type 1, well, maybe that's a misdiagnosis, but like lots of people are diagnosed with type 1 diabetes after having had diabetic ketoacidosis and like losing consciousness and having to go to the hospital, and then and how do we reckon we treat diabetic ketoacidosis?
Not type 1 diabetes, but ketoacidosis.
Yeah, ketoacidosis. So they come in, their blood sugar's like 30, it should be less than 11. They're super sick, dehydrated. Yucky. Perfect. Insulin, and of course hydrating them, making sure they're really, really well hydrated. And then you tell them that they've got type 1 diabetes and they have to take insulin for the rest of their life. Whereas type 2 is caused by...
Is it resistance?
Perfect. Insulin resistance. Yep. And what's some medications that we would give for people with type 2 diabetes?
Not insulin, no. It's because they're resistant.
Yep. So metformin.
Isn't that for the weight?
No. So metformin is an insulin sensitizer.
Oh, is it?
Yeah. It's your first line of treatment for someone who has type 2 diabetes. Metformin also helps people lose weight.
Oh, okay.
There are other types of medications, like, I'm going to say this wrong, no, I'm not even going to try and say it. There's a type of diabetes medication which causes weight gain. People don't like taking it, but it still treats diabetes. Alright, question 16. You're on your GP placement and are asked to see a 19-year-old New Zealand European woman who has been drinking lots of water for the past couple of months. She can't go anywhere without a bottle of water. She says she does this because she is always going to the toilet and gets up 3 to 4 times each night to drink. She has a normal body weight. How would you investigate this patient? Renal ultrasound, fluid deprivation test, serum, ACTH levels, or bladder ultrasound?
Is it not D?
Not D, yep.
Not B? Or is it B?
So ours is B. We'll just go over it.
Oh.
So she's got diabetes insipidus, which is the
Oh,
opposite.
I've never heard of that.
What? Okay, let's talk about diabetes
We
insipidus.
didn't learn that in RDA though.
Yes, you should have. Oh, that's sad.
No,
if you
they
don't.
must have cut it out.
Sad. Okay, so diabetes insipidus. So diabetes mellitus literally translates to sweet pea, because your pea is sugary.
Yeah.
Diabetes insipidus is watery pea.
Okay.
So your pea's really watery. Now, what causes us to concentrate our urine in the kidneys? What drug? Not drug. Hormone.
ADH.
Perfect. ADH. So ADH is released by the pituitary gland, causes water reabsorption when we have high plasma osmolarity. So our plasma is really salty. We want to absorb more water to reduce that, and so our pee becomes concentrated. For people who have diabetes insipidus, either they don't release any ADH, or their kidneys are resistant to ADH.
Okay.
So their kidneys just do whatever they want. They always pump out lots and lots of watery pee and never absorb any water, or absorb very little water.
Oh, okay.
So this means these people have to always drink because they have to compensate for their osmolarity instead.
Oh, okay. That makes sense.
And they have to get up in the middle of the night to pee as well, because their body's not, when you're sleeping, you don't want to wake up and pee all the time. So your kidneys, and you're not drinking as well, so your kidneys like reabsorb all the water and wake, you have concentrated pee when you wake up, and that doesn't happen for these people.
Okay, that makes sense.
So what we do is a fluid deprivation test where we stop them from drinking water, and after a few hours we test their urine and we test their plasma. And if they've become hyperosmotic in their blood, but their pee is still very hypoosmotic, very watery, then something's wrong. Okay. And we can see if so there's two different types, central and nephrogenic. So central is the pituitary gland, nephrogenic is the kidneys. So desmopressin is fake ADH.
Yeah.
And so what we'll do is we'll give them desmopressin and see if the desmopressin works, it means that it's central. And we can treat it, we can give them desmopressin and then they can live a normal life. If it's nephrogenic, it's much harder to treat because we can't replace the receptors in the kidneys that don't work. So they kind of just have to treat.
Oh, because desmopressin does that.
It would have to bind to the receptor and the receptor would have to work. And that if that receptor's
whereas
not
if it's
working,
a kidney problem, it's okay. That makes sense.
Yeah, so if it's a kidney problem, you can't fix it.
Yeah, that makes sense. Okay.
So ACTH is for your adrenal gland, so that's not the right answer. And you could do a renal ultrasound, but you wouldn't see anything.
Okay.
Could do a bladder ultrasound, but you wouldn't see anything. Mostly you do fluid tests, and plasma tests and urine tests, and the fluid deprivation test is one way of fast forwarding the possible outcome. Okay, next question. A 52-year-old New Zealand European woman presents to a GP with hot flushes, night sweats, mood swings, and a lack of energy. These complaints have been present for the last 3 months and are increasing in intensity and severity. Her menstrual cycle is irregular with intervals between 1 and 3 months. She asks if she could try hormone replacement therapy. What is not a possible side effect of hormone replacement therapy?
Is that cancer?
No, there is cancer. You've got increased risk of cancer.
A side effect?
Yep. So depression isn't a side effect. Depression is a side effect of menopause, but you have increased risk of cancer, heart disease, and stroke when you're on HRT. So you want low dose for as short time as possible.
Okay.
And what is this woman experiencing? Doesn't say it here, but menopause exactly. Yep. Very good. And I think this is the last question in this one, and then we can, if you're happy, we can do the one from last week.
Yeah.
That one's GU and digestive.
Okay.
So, a 90-year-old man lives at a rest home, presents to ED with his third femoral fracture in 2 years. He mentions he's been getting shorter over the past few years. He finds it hard to get up from his chair in the morning. His measured serum calcium is low. What vitamin deficiency is he experiencing? A, B12, I just have it as B1, whoops. Vitamin C or vitamin D?
I don't think it's A or C.
A or C? No? What does vitamin B12 deficiency cause?
Anemia?
Perfect. So, probably
D.
Vitamin D. He's got adult rickets.
And what is it in kids? Oh, I thought it was rickets in kids and something else.
That's right. It's called osteomalacia.
Yeah.
So vitamin A is in carrots. This is how I remember it. It's for vision. You got poor vision. So I've written B12 and then B1 here. That's a bit dumb. Vitamin B1 is thiamine. It happens. It's decreased a lot in people who are alcoholics, and they get beriberi. Do you remember that?
I remember wet and dry beriberi.
Yeah, so that's vitamin B1 deficiency, thiamine deficiency. Vitamin C deficiency
What is
causes...
wet and dry beriberi? One's neurological and one's something else.
Yeah, I can't remember. Just remember
Okay.
beriberi. It's
Okay.
like my ding beriberi. Vitamin C causes deficiency. Get it if you're a pirate on a boat.
If you're what?
If you're a pirate on a boat, get scurvy.
Scurvy?
Yeah, that's vitamin C deficiency.
What's scurvy?
Your teeth fall out, you get really sick.
Okay.
That's vitamin C deficiency. And then vitamin D. That's what this person's got, vitamin D
Why do we take
deficiency.
vitamin C when we have a cold?